So, without further ado, I would like to introduce to you our guest presenter for the day. I'm very, very pleased to introduce Dr. Peter Jackson, who is co-director of clinical affairs at the University of Vermont Center on Rural Addiction and is also assistant professor at the University of Vermont Larner College of Medicine. He specializes in both child and adolescent psychiatry and addiction psychiatry. Dr. Jackson attended medical school at the University of Utah School of Medicine. He then went on to complete his psychiatric residency at the University of Michigan, and from there on to Harvard's MGH McLean for his child and adolescent fellowship before he was recruited to UVM in 2017. At the University of Vermont, he combines his expertise in child and adolescent addiction psychiatry with his work in family-based assessments and treatment approaches. As a member of both the American Academy of Child and Adolescent Psychiatry and the American Academy of Addiction Psychiatry, he currently serves on committees responsible for preventing and treating substance use disorders in teens. His writings and teachings have included additional emphasis on the role of parents and family members in the prevention and treatment of substance use disorders. Dr. Jackson today brings his experience on identifying bias and addressing stigma in the clinical setting. Please join me in welcoming Dr. Peter Jackson.
Laurie, thanks so much for that nice introduction, and thanks to you and Dr. Torville for the invite to come and speak. It's really nice to be together virtually. I'm glad we can at least do that. I always wish we could meet together in person, and part of that is I'm sure it's warmer weather in Tennessee than it is in Vermont right now. We've had snow this week, and we're still hoping for spring. So, but yeah, I'm grateful to be here. As I look at the things that I hope we can accomplish today, I've listed some of the session objectives. And I kind of reordered them as I was looking at this slide this morning and brought this first bullet to the top. And that's the one that I think I care the most about. And I think the people on the call or on our, in our meeting here care the most about is to increase compassionate care for those that are impacted by substance use disorders. I'm hoping that sort of recognizing the impact that bias and stigma can have on those individuals will help us do that we can think about ways to decrease our personal or organizational stigma and bias towards substance use disorders. I'm going to talk a little bit about substance use disorders and a disease model of addiction. And then hopefully by the end, we can build our confidence in our ability to sort of lead out in using language and treatment approaches that help these individuals and families. We also will talk a little bit about the implications that stigma can have on individuals, particularly from rural communities. Giving a talk about stigma is sometimes a bit intimidating because I know that I'll probably say a bunch of stuff during this talk without knowing it or without wanting to that can be stigmatizing. One of my favorite speakers often begins a talk by saying that his first audience is himself, and I feel that way very much. And I hope to sort of approach this with humility to know that I need this as much as anybody here who's joining us. I loved the stigma reduction plan that you guys sent out, Laurie, and so I wanted to just reference it here. And I think it's really good, especially on number one, identifying one or more pieces of new or refreshed information. That may not come from what I say, it might come from what you think and what you feel. And that's probably even more valuable. So I know that the people here on the call have a lot of experience. And I know that we have a really broad audience, individuals who are joining us from all sort of different professional approaches to this and life experience. So anyway, I really liked the stigma reduction plan and wanted to reference it here. And it sounds like, Laurie, you put that in the chat so people can access it. I'm going to just tell a brief story that I look back on, and I think it's somewhat ironic based on the direction that I ended up taking in my career. I don't know, maybe it was particularly meaningful for me. When I started medical school, I had no idea that I would practice in the field of psychiatry or the field of addiction treatment. I thought for sure I'd be a surgeon. And so I started medical school kind of with this not on my radar whatsoever. In my medical school and most medical schools, you spend the first 2 years really in the books, so to speak. So you're in classes, you're in lectures, and you're learning, taking these big tests. And then third year comes and you're bright-eyed and bushy-tailed and so excited to get back or get into the hospital. And I showed up, my first rotation was on the internal medicine service in the hospital. And I got assigned a patient who I was just so excited, and the chief resident that was working with me, we interviewed the patient and we met this individual. He was somebody kind of close to my age actually, and a little bit close to my same sort of family demographic. He had a young child, and so we met him, and he had these longstanding difficulties with infectious processes. And the team was looking into all of these conditions, and they worried that he might have some type of autoimmune disease or immune system deficiency. We worried that he might have a form of leukemia or another blood dyscrasia, and sort of looked at all of these things. I don't remember exactly sort of what microbiology we were looking at or the infectious agent we were looking at. Those things I don't remember very much. What I remember is walking into the treatment team one of the next mornings. It was within that first week, we were working with this individual, walking into the treatment team the next morning, and the chief resident came in really upset and angry and said this here on the slide. And I wasn't sure, so I was curious as to what had happened or who he was talking about, and it turned out to be this patient that we'd been working with. And that morning, sort of end of the night shift, early that morning, one of the nurses had walked in and found this individual injecting crushed Percocet into his portacath. It's sort of a subdermal port for someone that's got a lot of infectious processes. And so he was injecting himself with pain medication that he had crushed. And it was really interesting and sad to sort of see the way that many of the members of the treatment team sort of turned. It was sort of like if it was an infectious process, or if it was these other causes, then we would rally. We would sort of be there for him. And but I saw a lot of people really get angry and really get upset and really stop their compassionate care for this individual. So that was an introduction to me of a type of stigma and bias that I think really can impact our medical treatment negatively. Now, I doubt that anybody who is here participating in this webinar would walk into the room and say that about the person, or would refuse to provide care or anything like that. So I recognize in thinking about this, there's some aspect that I think about, well, people who are attending a webinar about stigma and bias, maybe we're preaching to the choir. I think, like I mentioned in the beginning, this is something we all can continue working on. And I wanted to reference one of the data points that we came up with through the University of Vermont Center on Rural Addiction when we sent out a needs assessment to providers in the community. We were trying to get a sense in rural communities what the barriers are, how we can help more, and particularly helping address substance use challenges in rural areas. And so one of the questions was, please select the top 3 provider barriers to treating opioid use disorders in your practice. And the least commonly selected barrier was provider stigma. So people, I'm going to exaggerate this a little bit, but people are basically saying, no, that's not a problem for me, or that's not a problem for us. The most commonly selected barrier was medication diversion. And those two things combined, those 2 data points, don't make a lot of sense to me. In fact, I see them as a bit contradictory. To say, no, I don't have stigma, but my number one worry is that this patient population is gonna misuse whatever I'm trying to give them. Or anyway, so And these are providers who are interested in providing care. They're sort of self-selecting in the survey because they were interested in participating with us. So, and then we asked, what are the top 3 patient barriers to treating opioid use disorders? And stigma was chosen as being second only to transportation difficulties as the most commonly selected response. So again, exaggerating this a little bit, I see sometimes we think, no, I don't have stigma. While we do, myself included, and then sometimes we think the stigma is somebody else's issue. So yeah, the patients definitely have a stigma barrier, but I don't have a stigma barrier. So I think we have to approach this with a little bit of humility for all of us and think about how it impacts us. Even those of us who have the very best of intentions and want to, like those who are here on this webinar, and want to really be part of the solution and part of the help in this area. So I want to just think briefly, people who do research on stigma often break it up into sort of different types of categories, and I hope this helps us think broadly. So experienced stigma down there at the bottom of this slide, that would be like what happened in that setting in the hospital. Somebody is called bad names, somebody is not being cared for well, they're actually experiencing it. Perceived stigma is people's worry about that potentially happening, what's going to happen. Anticipated stigma is individuals thinking, this is coming in the future. If I do this certain thing, then this next thing is going to follow because of what I'm going through. Internalized stigma can be that sort of feeling that an individual might have about themselves. And when we think about, again, sort of breaking stigma into different aspects, starting sort of top to bottom, I think some of these are easier to see or easier to identify within ourselves, and some of them are more subtle. We often, people who research stigma often and bias often say that the most dangerous bias and stigma that we have are those that we don't know about, that we don't recognize. So starting with stereotypical beliefs, a belief that someone with an addiction or a substance use disorder is acting in a criminal way, or they're an unintelligent individual. Attribution beliefs of sort of why it's going on, and we're going to talk about that a little bit during this webinar. That someone with an addiction is in control, or they should be in control, or that they're responsible for what's happening to them. Expectations for recovery can include stigma. We'll talk about that a little bit too. Someone with an addiction will or will not be able to recover, find a job, maintain relationships. Sort of what are our beliefs about that? And then social distance. Wow, that's interesting. Living in this past year of social distancing, but we think about, asking yourself the question, I'd be willing to have someone with an addiction live next door to me or sit down by me on a train. These types of things is a specific aspect of stigma that can get in the way. When we look at stigma, particularly in rural areas, we've looked through this, and the amount of good literature that we have on it is really small. I want to try to talk about this in ways that's not further stigmatizing, because I think we can sort of define rurality in a way that's also stigmatizing. And so as we are thinking about this in the Center on Rural Addiction up at UVM, we need to be careful about that. Right now, I live in a town that has 1,600 people and no stoplights. So am I, do I count as a rural person? I've only lived there for 4 years. And before that, I lived outside of Boston and, lived in the total madness of that. Before that, I lived in a town of 4,500 people and 2 stoplights. So I sort of think about that, like what makes me rural now because of where I live versus not because of where I've been. So there's a lot to think about here. And again, we have to be careful to say, like, everyone in a rural area needs this type of help with substance use disorders. We need to be kind of cautious about that, but I will mention this during the talk, since that's a lot of what we're working toward in our center and what your group is also working on. So some studies do show differences. There's sort of known relationships at times between some masculine norms where self-stigma might prevent men more than women from seeking help. There have been some studies that have shown this is maybe more strong or more intense of an effect in rural areas. There's one study that showed higher self-stigma and public stigma amongst older adults in rural areas compared to urban settings. There's one study that sort of looked at this, trying to understand stigma regarding substance use disorders, that showed no differences at all. That study had an interesting way of recruiting its participants. So I think there are differences and things that we need to be aware of and think about, but be careful not to further stigmatize as we're thinking about it. So this, I think, goes without saying, but I wanted to just mention this study and put this down as a slide, is stigma is incredibly common, and stigma towards substance use disorders is incredibly common. This study was done back in the early 2000s, but sort of ranked a bunch of conditions that tend to be thought less of or looked down upon, and found that drug addiction ranked #1. And again, this is World Health Organization study, so looking very, very broadly. And alcohol addiction ranked #4 amongst the most highly stigmatized conditions. So it's really common, and the impact is incredibly detrimental. So individuals who are themselves affected by a substance use disorder, they will be less likely to seek treatment, which is a huge problem that many of us have seen. There's so few of individuals who meet criteria for a substance use disorder who are actually receiving treatment. Estimates are usually around 10%. 10% of people who need treatment are getting treatment. There's a poor prognosis when people feel stigmatized. There's a decreased likelihood to complete treatment, lower self-esteem, them feeling less empowered to be capable in their treatment, and then social alienation, including employment opportunities lost, difficulty finding housing, which all leads to a further lack of connectedness. Impact on professionals and individuals who are in they're in a position to help out and help be addressing this problem is that there's lower individual regard. And when I think of individual regard, sometimes it might be thinking less of someone. It might also be thinking of someone less. And there's some nuance to that. You know, we may not think, oh no, I'm not thinking down about that person, but we may just feel, if we feel a sense of hopelessness or discouragement, we may just, you know, that person's not rising to our attention. There's decreased motivation sometimes. There's feelings of dissatisfaction, resentment, or powerlessness that, you know, if these conditions are stigmatized, and that can result from a perception that individuals won't be motivated, or that they're manipulative, or that they're potentially violent. These are things that have been studied. They're asking surveys of providers what this looks like. And then there's a potential that we'll miss opportunities to provide care. I wanted to give the example briefly of pain management. What I've seen, ironically, more often with the patients that we're working with at the University of Vermont, let's say someone's going to have a major surgery. I think we used to be in sort of a policing attitude where we feel like, no, I'm going to sort of alert everybody. This individual can't get pain treatment because we're too dangerous. We find ourselves very frequently needing to advocate for the individuals that we're working with and helping be a part of the solution, and saying, no, they actually really need to make sure that we monitor and manage their pain management well, because they may have a higher tolerance for opioids, for example. So this is something that really impacts individuals affected by substance use disorder themselves, their loved ones, and professionals who are in caregiving roles. Language is a huge part of the problem for stigma. I think this slide, something like this slide, will be in almost every talk that's given about stigma right now. It is important, and I'll show one study that sort of assesses this. So it's certain language that we can use, like if we continue to refer to somebody who's using substances as dirty and somebody who is able to abstain as clean, those words just carry so much, there's such connotation to those, negative connotation to somebody feeling dirty. So here's an example of a few words that we tend to try to avoid in our treatment. But the language that we are so prone to use, we come by a little honestly because it's probably what we've read in books, it's what we've seen. Just so that you're aware, sort of help with language is included in a lot of the resources that are at the end of the slides. And so I'm happy to, share these and pass them along. But again, it's really widespread. It's really in high places and has deep roots, the language that we've used. So this has come from our political efforts towards addressing this issue as a country, where if we use language like it's public enemy number one or the war on drugs, that really sort of creates this this perception that we have to be careful with. An act that was done back in the 1980s, the Anti-Drug Abuse Act, led to minimum mandatory sentences for drug offenses. That seems a little ironic to me. That seems a little unfair, frankly. And then our national agencies are using words like abuse. And pay attention to that word specifically, because I'm going to show you some results of a study that was done. So SAMHSA, NIDA, these are national agencies that still sort of contain this word abuse. So instead of saying somebody has a substance use disorder, if we say someone has substance abuse or is a substance abuser, that makes a really big difference, which I'll mention in a study in the next couple of slides. In addition to that type of language, sort of trying to avoid those more stigmatizing terms, I think it's important for us in general to try to use person-first language. Instead of referring to somebody as a diabetic, it's an individual with diabetes, or an asthmatic, a person with asthma. So again, instead of addict or substance abuser, a person with a substance use disorder. This makes a big difference and helps us think of people as having conditions rather than being defined by conditions. So here's a study that was done by John Kelly down at Massachusetts General Hospital. And here's basically a survey that was sent out to providers. Mr. Williams is a substance abuser and is attending a treatment program through the court. Mr. Williams has been a substance abuser for the past few years. He now awaits his appointment with the judge. So this was included in a paragraph. You're just telling the providers, here's a clinical case scenario, and getting them to sort of give thoughts about what they would do or what they're thinking, as opposed to Mr. Williams has a substance use disorder and is attending a treatment program through the court. Mr. Williams has had a substance use disorder for the past few years. He now awaits his appointment with the judge. So there's only one difference in those two, and I don't have the whole paragraph here because it's lengthy, but there's only this difference in the entire paragraph, that he is a substance abuser and has been a substance abuser for the past few years, or he has a substance use disorder and has had that substance use disorder for the past few years. So after providers read this, and this is respondents who have 65% of the respondents have a doctorate degree. Most were mental health professionals, but there's a statistical difference in what they believe about Mr. Williams just from those paragraphs. The only thing that changes is that one terminology. So these are the type of questions where there's a statistical difference in the responses to what people believe about this individual in the vignette. His problem is caused by a reckless lifestyle. He's responsible for causing his problem. He should be given some kind of jail sentence to serve as a wake-up call. His problem is caused by poor choices that he made. He could have avoided it. He'll do something violent to himself. I believe he'll do something violent to others. That's a huge wake-up call, I think, for us. And I think this study is so poignant, and John Kelly has done other studies along sort of in this regard. But I think that's fascinating. This is not 10-year-olds that are being asked about this. These are people with doctorate level degrees, people that are mental health providers and healthcare providers. And there's this different response just on that one term. Another thing that I think can contribute to stigma is some things where we as a field of treating substance use disorders, we've occasionally had sort of these errors in thinking where we've sort of thought in all or nothing type of thinking. One example is sort of an individual is either ready or not. And that sort of has given way to what many of you know as the stages of change, first proposed by Prochaska and Di Clemente, pre-contemplation, contemplation, preparation, so that's helpful to not think in those sort of all or nothing ways. Abstinence-based versus harm reduction is sort of, you're either going to do it my way or there's not a way, or, we're this sort of binary where as a provider, you either have to decide, are you going to be abstinence-based or are you going to be a harm reductionist? That's not helpful either, I don't think. And I think this I hope gives way to us recognizing that there's individual paths to recovery. A sort of binary thinking, like you either have this expertise in your clinic or you don't. That's not helpful. And more we're getting both mental health treatment and substance use treatment embedded within primary care. So another area where we've made errors in the past is to tell people, you know what, we can't take care of your anxiety or your depression or whatever other mental health condition you're struggling with until you fix your addictive behavior, So that used to be the case. I remember sort of learning that actually. Well, tell that person that the treatment for the substance use disorder has to come first. We can't help anything else if you're going to be using substances. That's also not helpful. We realize, and now more and more, it's dual diagnosis, it's co-occurring treatment. We work on everything all together at once, and we address it. And then more recently, this question of like, is treating substance use too scary to do? With buprenorphine treatment, they unfortunately called the license to become a waivered provider to prescribe buprenorphine an X license. That makes it sound kind of off limits to me. An X license, it sounds kind of, I don't know, it sounds a little scary, and you're waivered to do this or you're not. And that's something where we're starting to see movement, where there's actually been some legislation proposed that's going to allow, and some that passed, but it's still, it's being argued that is going to allow us to sort of take better care of individuals with an opioid use disorder without this extra barrier. So this is something that I'm going to encourage us to think about, is to recognize that there are ways that we have adopted stigma in sort of these kind of all or nothing type of situations. Just want to revisit this and re-emphasize briefly the results of stigma and bias: poorer health outcomes, less treatment seeking, less engagement in primary care. And one that I didn't mention before is less clinical providers that are educated in that field or area of expertise. I'm going to own this for myself and mention that I feel like I had to overcome what felt like a mountain of sort of outsider opinions and then my own opinions about what I was going to take on for my career choices. Going in, I was going to be a surgeon, and that's so cool, and that's something to sort of cheer and be really proud of. And I remember people just saying, "Wait, I thought you were going to be a surgeon. Why would you want to do that other thing?" I remember a neighbor saying, they literally said, "But you're so normal. Why would you do that?" It left me kind of dumbfounded, and I still think about that. So the stigma associated with these conditions can pass on to those that really want to help individuals struggling with these conditions. It can lead to less education, less full-time employment, social isolation. We talked about other mental health conditions like anxiety and depression. And I just want to mention that this is a ubiquitous problem. It's worldwide. This study done by Kane and colleagues in 2019 included an assessment of stigma and bias towards substance use in countries around the world. Every continent is included in this assessment. It's all over the place. So briefly, let's think, I guess, a little bit about the rural implications of stigma and bias regarding substance use disorders. There is something about word of mouth information about the level of compassion in a given clinic sort of passing within a community more quickly when a community is smaller. And if the word is, I felt really judged there, or I felt really uncomfortable there, I felt dismissed there, there's nowhere else to go. That's a quote from patients that I've worked with from some of the most rural areas in Vermont. There's nowhere else to go. If I don't go to that clinic, where else can I go? There's a higher likelihood for individuals to be connected through multiple roles or settings in a smaller community, which also links with that last bullet, a possibility for decreased privacy. This can be a challenge because going in to receive help, you're much more likely to bump into somebody that you know in another setting. The healthcare provider might have children in your children's school class, for example. On the other hand, the fact that substance use disorders are almost of necessity embedded into primary care might be a benefit in rural areas, because there's not this sort of addiction clinic, this place. If you drive past substance use treatment centers, so often there's nothing on the outside of that building to say what it is, because we want to keep that quiet. We don't want people to know what's going on. So the fact that treatment that can be embedded within primary care may be a benefit. And then we do see that rural areas can have a culture of self-efficacy. They're farther away from some of the easy resources sometimes. And so there's this culture of self-efficacy and self-sufficiency. People might have grown up generations and generations. If something breaks, we take care of it. We fix it, we rally. So there can be this, like I mentioned in that earlier slide, there can be this feeling like, no, I'm going to take care of that on my own. I don't need help with that. So all of these things we need to consider. I went recently to visit a physical therapist. There's this tiny office in my town. Never had met this person before. And I walked in and this individual knew everything about me. They were being very friendly, really nice, but knew everything about me. It was a little bit like, oh, that's interesting. The car that we drive, the type of pet that we have, who's who I work with, all of those things. So there are these implications in rural areas that we can be aware of. And being aware of is better than sort of just believing and labeling, again, kind of decreasing stigma. So another study that sort of assessed rural implications of stigma found mostly this middle bullet point, that stigma tends to be highest in the general public and next highest in general practitioners, and then lowest in specialists. That kind of feels like a no-brainer to me. It's not like a big aha, but we realize that in rural areas, there tend not to be specialists. So the overall average stigma may be a little higher. We also see in this study that more frequent contact and familiarity are associated with reduced social distance toward an identified group. There's so much for us to think about there. Again, that may feel like sort of a no-brainer, but the more you are exposed to take care of, interact with somebody who's struggling with a certain condition, the less you're going to be sort of worried about it, afraid about it. And so exposure decreases stigma. Another thing to consider in rural areas that I think is important, kind of going back to this single path to recovery, this study found that there's a higher likelihood of access to legal substances in homes in rural areas, alcohol, tobacco, other nicotine products. And so this might be a particular area to be careful to not sort of say everything is bad and we're not gonna accept a really strict abstinence-based type of program. Maybe a little more off-putting to somebody for whom this was much more normal to know that there's nicotine in the home, there's alcohol in the home. Not that we would sort of condone or encourage by any means nicotine use or alcohol use challenges, but something to be aware of, that that's kind of a higher frequency in rural areas. So what do we do about our difficulties with this stigma and bias? First, I want to briefly mention two main areas where I think stigma can happen, and that's in the area of cause and the area of controllability. And we'll talk about those a little bit. So the first one, an area of stigma, is why did this addiction happen? Why do substance use disorders develop? Is this somebody's fault or is this not somebody's fault? This is sort of a good introspective question, but it's not, this should not be an exercise in blame. Like, all right, we're going to categorize out and we're going to distribute the blame for this problem. But the cause of a substance use disorder is something that can be very, very stigmatized and can lead to increased bias. So briefly, and this is something that's really important to me in my own work, because I think about substance use disorders in young people because I'm a child psychiatrist, and I've come to sort of think in a cyclical way for substance use disorders. People might have said to me in the past, oh, that's really cool, you're going to be a child psychiatrist and an addiction psychiatrist, so you'll be able to work in the area of prevention because you can work with young people. My feeling is that prevention should happen and can happen no matter who comes into the office, because it's a generation to generation challenge for so many families. So if you're preventing for a 14-year-old, a 12-year-old, an 8-year-old, if you keep going back, then you just end up back at the next generation. So we can prevent no matter what. That's a little bit of a tangent. But I want to just mention that about half of the risk, attributable risk, and the heritability for substance use disorders, about half of that risk is sort of thought to be genetic compared to environmental. So we think about, well, did this certain thing happen because of nature or nurture? The answer really is both. So we know that there's heritability to it, and it happens to be the same heritability towards other conditions that we're pretty familiar with. Type 2 diabetes, prostate cancer, just a couple of examples where there's about this same estimated heritability. So I think about this a lot. If let's say 100 college kids or 100 high school kids go to a party and there's substance available there, let's say there's alcohol available there, and they drink too much and they're sort of envisioning that as part of the party and part of the way to have fun. There is a percentage of those kids, we would estimate about 15%. So 15 of those 100 kids, for no fault of their own, have an experience with the alcohol that's different than the other kids. Everyone's experience is obviously different, but there's this percentage that have an experience that's different. Sort of the likability, the impact that it has on them is different, and that's for no fault of their own. That's the genetic risk that I'm sort of talking about. This is a slide. I don't think I'll go into too much detail on this slide, but this shows us that it's nature and nurture. Oh, sorry, that says nature of nurture. Nature or nurture. This study was done with what they call a triparental design. So you take a parent who gives you nature and nurture. You take a parent who gives you only nature genes. So this would be like a parent who is your biological parent but hasn't lived with you at all. And then you take a parent who only gives you nurture. So not your biological parent, a step parent, but who's really your parent in the home. And you look at all three of these situations. In this case, it was a biological and lived with mother, not lived with father, and a stepfather. And the impact of all three of these things is significant. Basically, this study is saying your risk is higher, not only if your biological parent has a substance use disorder, but also if your nurturing parent has had a substance use disorder, and you sort of watch that happening. So adverse childhood experiences, really commonly known, the ACEs study and all the sub-studies that have happened after this, this is one of the adverse childhood experiences that we should be thinking of. In fact, the highest likelihood household challenge among the adverse childhood experiences was substance use problems. And there's that word again, substance abuse. I may have said it during this presentation. We're trying to get away from that word as best we can. So 27% of children are facing this challenge in their home. based on the original sort of adverse childhood experiences study. Again, the reason I'm bringing these slides up is to think about how can we think of the cause of substance use disorders or the development of substance use disorders in a less stigmatizing way. So this is sort of a developmental hypothesis about the cause of substance use disorders that came from the Journal of Pediatrics back in early 2000. This is from Joe Biederman, who also is down at Mass General Hospital. So you look at all of this, and I know this slide's a little bit small and hard to see, but you look at all of this and you consider, wow, how much baggage might have been contributed. And that's not a great way to say it, but how much is this kid carrying as they were prone, maybe much, much more prone than their peers to find relief in or find likability in substances. The access to substances, widely different. Social adversity that children have come through, stressful events, parental monitoring, we talked about all those things, but this can help us, I think, really increase compassion and decrease sort of stigma, like, this is your fault, you chose this, you're digging your own grave, so to speak. This can help us, I think. So let's say we get over that hump and we can sort of be more compassionate and stop sort of the blaming, like, well, you chose this. Let's say we get over that hump and we're still struggling with this. Okay, well, I'm sorry that this happened to you, and I can see that it's not really fair for me to say this is all your fault. But now can you just change? So the controllability is another area where stigma can really get in our way. And I want to just briefly mention the disease model of addiction. So the science around this, I get kind of geeked out. It's really fascinating to me. This is not meant to be a neuroscience lecture, but if you want a digestible paper that explains this pretty well, this paper from Nora Volkow is really good. It's from the New England Journal of Medicine in 2016. And it talks about the disease model of addiction. And I want to just highlight, the image is not great. You can pull it up in the paper, but sort of these stages of use, the use itself, the sort of after use period, which for some people, becomes withdrawal, and then the in-between use, which is sort of like the waiting or thinking about the next time. So the use goes from sort of, maybe voluntary in the middle, I'm going to choose to do this, and then starts to become impulsive rather than sort of more of a conscious choice. It's this impulsive use. And we see brain changes of why that's the case. The feeling that one gets, that high or the euphoria from initial use, we can see brain changes that then describe, it's no longer this great feeling that I'm getting. I just have to get away from the bad feeling of not having it. So escaping dysphoria instead of having euphoria. And then withdrawal symptoms can start out as like, oh yeah, I feel crummy. I used a substance and now my body feels like it's sort of recovering, and I feel lethargic, I feel junky. So it can go from low energy to reduced excitement to getting restless, and then towards anxiety and towards depression. And then we know, particularly with benzodiazepines, alcohol, and opioids, the withdrawal for those first two categories can be lethal. And the withdrawal from opioids in particular just is a horrendous experience. So these individuals, many of them, and I've heard this story just again and again and again. In the beginning, it was fun. In the beginning, it was exciting. And within a pretty short period of time, 1 to 2 years, the whole thing became about not getting sick. That was my whole day, is waking up and trying to figure out, how am I not going to get sick? So that's when sort of looking forward to something then turns into obsessing and planning, and it just occupies so much bandwidth. So this is the disease model of addiction, and I spent more time on that slide than I promised you I would. So as we think about that, thinking of the disease model, the question comes up for some people, is substance use a problem or is it a disease? And this has been debated back and forth and sort of argued and argued. I definitely subscribe to the disease model of addiction. Someone asked a great question last time I was giving a talk about this. We have to be careful that we don't sort of apply the disease model of addiction to someone who's experimented with a substance once or twice. That is not the disease model of addiction. It doesn't happen like that. But there's a need for some balance here, because sometimes when people identify it as a problem, they might see this as, okay, problems we can fix. Diseases, that's can be really hard to fix. So, but the cons of viewing it in a problem way is that people will see it more as like, this is a moral failing. If you had enough motivation, then you'd just be able to change, just try harder. When we think about it in a disease model, this can increase our compassion for the causality and the controllability and lead to less blaming. But we do need to be careful about that too, and not lead to this really, this sort of prognostic pessimism that this thing's not going to be able to be fixed. It's too ingrained. Or even thinking about that heritability part that, oh, well, my dad and my grandmother had a difficulty with substance use disorder, so I'm doomed. So we have to be careful. We have to be careful about that. And this is where I'm asking us to sort of look at a balance in how we think about it. We have to balance reducing blame against sort of feeling pessimistic about the prognosis. There's this other study by John Kelly where they're sort of looking at how many tries it takes. And this is one example where I think our efforts, well-intentioned efforts to say, hey, we gotta stop treating individuals who are struggling with this so badly, because this is a disease, and it's a chronic relapsing remitting disease. And there is truth to that. But if we then say, yeah, it's gonna take you 9 times. It's gonna take you 9 times in rehab to get better. Super discouraging. And so John Kelly, again, he's kind of a warrior on this. He did this study to kind of look at how many attempts in recovery does it really take? What does that even mean? What's a recovery attempt? But I remember being taught in the beginning, like it was a fact, that it takes 9 tries in rehab to recover from a substance use problem. That's just not useful in information if we apply it in a pessimistic way towards the prognosis. So he looked at this study and sort of found that while there might be an average that's pulled out by people that have tried. So the average might be higher, but the most common answer in those studies might be closer to 2 or 3. I don't think it's really that useful to say to a patient, well, I know how many tries this is going to take for you. But the reason I bring this up is because if I'm thinking it's going to take 9 tries, that might be really not very helpful, when more commonly people are, getting significant recovery on their second time seeking to enter treatment. So we're balancing this. And I also sometimes get kind of nerded out. I'm really excited. And I'm explaining all this neuroscience. And I'm hoping that this is going to decrease stigma for an individual or a family. But sometimes we need to make sure that we don't let kind of the causality get in the way of us just providing good treatment. There's this study, and this was for mental health conditions, but the study is entitled, I don't have to know why it snows, I just have to shovel it. So again, applicable for shoveling snow still in April in Vermont. But I think that kind of makes sense. Sometimes people are like, you don't need to explain to me every detail of how this happened. Sometimes they just say, let's just work on it. So, okay, so circling back, thinking about sort of strategies and what we can do about this. Again, I'm excited to think of the stigma reduction plan being passed out to those that are attending. And I hope that all of us will have the chance to do that as we finish talking together. But so as we think about, I have a few slides here of things that we can do. And they start with sort of more logistics, and they're going to end with more of sort of, I think, what we sometimes call the soft skills. So logistics, we can increase contact between an affected population and a larger population, and that will decrease stigma. There's lots of studies about that. So that might mean that in training, for example, we need to find ways to get medical students and nursing students and social work students, and all sorts of, trainees who are working in this area to have opportunities to see this beautiful area of medicine where people make amazing change. We need to have mental health and substance use disorder parity laws so that these get covered. We have this carve out thing that's such a mess. It's sort of like, yeah, we'll cover you for all your medical conditions, but those other things like mental health and substance use treatment, no, that's a carve out. Someone else is going to take care of that. So, we're making progress on this, I think, overall as a community. I will just say right here so that I don't forget to say it, we are moving in the right direction. I think medically, from a legal standpoint, from a medical standpoint, in so many ways, from a research standpoint, we're moving in the right direction. It sadly took a huge opioid pandemic for us to kind of open our eyes a little bit, but we're moving in the right direction. We can have, communication standards to avoid some of the stigmatizing language so that we're using person-centered language and person-centered treatment. I'll mention that in just a moment. Widespread access to treatment. So this no wrong door idea. I don't know kind of what your all experience has been, but sometimes the place where you receive substance use treatment in a hospital system is like in the farthest, farthest corner of that building or of that campus. We need to make sure there's not a wrong door or wrong place to look for treatment for a substance use disorder. Is it your primary care? Is it your emergency room? Is it your orthopedic surgeon? You know what I mean? It needs to be all these places where we're ready to provide service. And that's something that we're working hard on in our field. And we've been doing that in the University of Vermont lately, that if someone goes to the emergency room needing help with an opioid use disorder, they get an appointment with me within the next business day. I have this spot that's saved always so that someone is ready. That when someone's ready, we're ready. We're ready to provide that treatment. So increasing access. Understanding the disease model of addiction can help us a lot. Understanding heritability that we've talked about, that it's both nature and nurture, can help us decrease our stigma against causality. Balancing both of those with making sure that it's not leading us to prognostic pessimism. Recovery-oriented treatment is something that I want to reference, and I didn't talk about this much in the talk so far, but I think sometimes we can get very scientific, and we need science, we need data, we need numbers, but we can sort of forget that we're not treating somebody's addiction severity index number. We're helping an individual. Same thing with anxiety or depression. Like the GAD, the GAD-7 or the PHQ-9, these are anxiety and depression measures. And I think sometimes like someone's on our appointment schedule, we sort of pull this up as clinical providers. It's like, well, what's their number? Is it better or worse? What we should really be asking and what's life looking like for you when you're well? So if somebody comes in and says, substance use is getting in the way of me being with my family, and I want to go fishing with my granddaughter, the question should be first, not, okay, what's your number looking like? It should be, hey, have you been fishing with your granddaughter? And that helps people feel cared about, that their condition does not define them, but that it impacts them and what they want to be and do. We also need to tell stories. And this, I think, it goes along with the increasing exposure. Making things, one of my favorite mentors in child psychiatry sort of would remind me that one of the best things we can do for a family is make a hard thing talk aboutable. And so I think about that term all the time, finding ways to make this talk aboutable. This is sort of an area of research that I'm trying to work on with multiple generations, but being able to facilitate communication about these hard things, to communicate about it with our friends and our family. I have people sometimes that will come up to me when I'm meeting them, at a gathering or something like that. What do you do for work? I tell them what I do for work. And there's this sort of like gloomy, like, oh, I'm so like, oh, you must be such a tough person, or kind of this almost like, I'm sorry you have to do that hard thing for your job. And we need to respond more often and say, I love what I do, and share those stories of success, share that excitement about how amazing it is to be able to walk with somebody or be witness to an amazing change that helps so many aspects of their life. We need to ask the people that we're working with, clients and patients, ask them, what's it felt like to be here? Is there anything that I've said or done that made you feel like discouraged or made you feel, like less than? So getting that feedback is really important. Asking ourselves those honest questions, some of them at the beginning. And I think, again, the stigma reduction plan, the personal stigma reduction plan is good. We need to do this, again, myself included. We need to own and recognize our countertransference. That's a psychiatric term that we use that basically means, what am I feeling back towards this person? What am I really feeling inside? If I'm feeling feelings of anger, feelings of frustration, feelings like, hey, I worked so hard for you, why would you go and make that decision? That's something we really have to recognize and work on with a team. Working with a team is critical for me, not only in this area, but I think just as we're working to help people. So working with a supportive team, being humble enough to ask your team for feedback, and then being confident enough to give your team members feedback as well, or at least asking those hard questions. I want to kind of wrap up with this idea, and I mentioned we'd sort of get to the soft skills in some ways. Carl Rogers was an individual counselor and therapist. He sort of coined this term, unconditional positive regard. Unconditional positive regard. It is so powerful, and it is something that I feel we can seek. It is not accomplished in a day. In fact, if you accomplish it today, you're going to have to try to re-accomplish it tomorrow. That's at least how I feel. This unconditional positive regard, that regardless of what somebody's been through, what they've done, their experiences are, we can have positive regard for that person. His sort of quote about this, the idea of unconditional positive regard is that the individual has within him or herself vast resources for self-understanding, for altering her or his self-concept, attitudes, and self-directed behavior. And that these resources can be tapped if only a definable climate of facilitative psychological attitudes can be provided. This goes along really well with with the idea of motivational interviewing, which is that really we are a privileged participant in helping somebody try to make change. That really the power for change is within them, not within us. Not if I give the most perfect description of the disease model of addiction, or if I give the most perfect motivational sort of speech. The power to change and the decision to change and the growth is really within them. So we have, I think motivational interviewing for me is such an important place to start in substance use treatment. So I definitely wanted to mention that. Lots of tools and resources here available that I wanted to list. And again, I can share the slides. When we think about evidence-based practice for medical care, I think we need to remember that this is a Venn diagram that I remember from medical school. It is not just find me a randomized controlled trial that tells me what to do. It's the combination of those trials, those papers, that research, that data, with our own experience, combined with what the patients and families value and want most. That's where we do our very best evidence-based medicine. And I hope that can sort of prompt some of the questions and discussions that the group might have. I'm really grateful for the chance to join you all. And thanks so much for the invitation, and thank you so much for having me. Laurie, I know, so I had kind of a tight window today, and I apologize for that, but I do have 15 minutes that I can stay on if that's useful. So.
That's wonderful. Thank you so very much for the excellent and very, very informative presentation, Dr. Jackson. At this point, we do have one question that I've seen, and June, you can correct me if there are more. But the first question is from Patricia, and how best can ACASA help the children for whom they're advocating that their parents suffer from a disease and that they can be helped?
So the question is, how can a household where parents have been struggling with substance use disorders let kids know about it?
Yeah, I think, Patricia, you can correct me. Are you a CASA?
Yes, I am.
Okay. Do you want to elaborate on your question to make sure you get the best response possible?
Okay. A CASA is a court-appointed advocate for children, and we advocate for children in court in cases of abuse or neglect of that child or children. And we often have to talk with the child about their parents' addiction because of the questions that the children have about it.
Yeah. Thank you for asking that question, Patricia. And that sounds like wonderful work that you do, and also challenging work that you do. It's so important. That's a really good question to ask about. And this is where I personally, I'm sort of a moderation in all things type of believer. I think it's really important that when we, in those types of settings, that we speak to children in a compassionate way. I think that children need to know, there's a few things that children need to know. One is that it's not their fault. That's a thing that children so often feel when their parent is struggling with something, that they must have caused it because they behave badly, or so that it's not their fault. That they can't control it, and they're not responsible to cure it. But that they can absolutely have resilience within them, and they can choose how they're going to respond to that struggle. I think right now we're sort of launching a study up here where we're going to try to take parents that are early in recovery and see if we can do a multi-generational approach to understanding the impact of addiction on families. If there's a situation of child neglect or child mistreatment or child abuse, then we would definitely not do that. We wouldn't ask a child to sort of come into a situation where they're feeling like they're being told that it's okay that you were treated that way. Does that make sense? So this is a really nuanced place, Patricia, and I just admire so much the work that you do. I see it as really, it's really important to sort of get a sense of what that child has been through, because if a child has been through traumatic experiences, we don't want to be seen as sort of trying to justify why those happened to them, because it's not justified. That's not the message that they can have. The message always for a child that's been through abuse needs to be, this should not happen. This was wrong. It's not your fault. And you aren't responsible for fixing or controlling it. Does that make sense, Patricia? I think we need to stay there first, especially if a child has been through abuse. Down the road, if a child has been through disappointment, that's a little bit different. So I think it's really important to know what the child has been through before we sort of pick our path forward. Because I think there's a real avenue in a place where a family's been impacted negatively by substance use disorders. There's a real avenue to help healing, but that's not an avenue that we want to start walking down when a child's in a setting of abuse, if that makes sense.
I appreciate that. I've been a CASA for 35 years, and I have seen that the number of cases where substance abuse involved has greatly increased. So this is a real problem for us in dealing with these children.
Yeah. There's a quote I love from Mr. Rogers. He said, anything that's mentionable is manageable. So, and before that, he says, I think I might botch it. I think he says anything that's human is mentionable and anything that's mentionable is manageable. So we also, it's really difficult, but we also don't ignore it. We don't sort of, pretend that didn't happen. Like, no, that's too secret. That's too private. There's actually a Sesame Street episode that I want to say that aired like, I don't know, 2 years ago, 3 years ago. Like, this is good. We can take these things on. We can talk to families about these things. There's a little Sesame Street character that has a parent struggling with substance use problems. That might be worth looking into, Patricia. I don't know if I can't give you the exact link, but I think if you Googled Sesame Street and parent substance use, this would come up where you could look at that. There's precedent for real benefit in children being able to understand and sort of know what their parents are going through. There's a whole program, but from my colleague that said making things talk aboutable is one of the biggest gifts you can give. Her whole program, her name's Paula Rausch, her whole program is helping parents talk to their kids about cancer from their diagnosis, and if it's a terminal condition, all the way up until death. There's another whole program through a group at UCLA of helping parents talk to their kids about deployment, post-traumatic stress disorder, and the difficult impact of military service that can have on kids. So there's precedent for this, that by being able to talk more comfortably with kids about parents' struggles. There's precedent for this in depression too. Lots of research about, if a child can know more of what that means, that a parent's struggling with depression, that it benefits the child in understanding. And so of all these conditions, this major stigma, substance use problems are so hush-hush, like, no, we don't want to talk about that. And we especially don't want a child to know about that. But in all reality, they usually do know something about it because they're living it, they're watching it. So I don't know, hopefully that's useful, Patricia.
Yes, it is. Thank you.
Thank you. We probably have time for one more question, given you said you had until 2:15. Is that correct, Dr. Jackson?
Yeah.
Okay, so I'm going to go in the order the questions are appearing, and then maybe we can email you the other two questions, and perhaps you could follow up with an email.
Sure.
Okay, and I can share it with the rest of the group. Thank you. It has been my experience, this is from Jan McCoy, that the behavior characteristics of someone in an active addiction are lying, manipulating, and stealing. This behavior has been a barrier in reducing stigma. How can we address this?
I think so, Jan. I think sort of where that question is coming from, and forgive me if I miss sort of interpret, but it seems like, well, there's a stigma about somebody that they're going to be, let's say they're going to be violent, or they're going to lie, or they're going to steal, and we just have to give them a break on that. But then if somebody does lie or steal or become violent, how do we then break stigma when something's actually happening? That's a good question, but I think I think we have to attribute that to that individual and their choices. We can't attribute that to that individual and everyone else who looks like them, sounds like them, lives in the same town that they live in, has the same color of skin as them, or also has a substance use disorder with them. I think that's where we get into trouble, is sort of when we when we sort of apply certain traits that have happened to somebody to all other people that fall within that demographic. I think we have to try to be compassionate as much as we can. I know individuals who have also made those choices, and there can be a component of it that's super hard to understand. Unconditional positive regard would say, can I hold positive regard for this person regardless of their choices? So I think you're asking a really challenging question that we have to challenge ourselves back with and say, I have to let that experience be that one person's choice and their decision. I find personally that there are some ways when I can try to understand what was going on for you in that moment. Well, I was faced with feeling deathly ill or finding a way to not feel deathly ill. That doesn't make a decision, it's not to condone it, but it's to try to understand it better. I guess those are the thoughts that I have on that question from Jan. We can do one more if that's helpful, or if there's follow-up to that.
We can do one more. I think this is a short one from Mark, I believe. Can you review the quote about snow and having to shovel it again? Something to do with not dwelling on details? Perhaps that slide?
I don't have to know why it snows. I just have to shovel it. That's I'm trying to think. There it is. So that's the title of a whole study. And again, this study was done with mental health conditions in general, I think. But this idea, I don't have to know why it snows. I just have to shovel it. So I'll sometimes get into this sort of long-winded description to somebody of, well, let me tell you what's going on from a neurobiological standpoint. And that might be more useful for me to understand. Some people are really interested to know. But yeah, there's the quote. I don't have to know why it snows. I just have to shovel it. It's basically, I want to move forward. I want to start digging out. I'm less interested in knowing about the science behind snow.
Well, Dr. Jackson, again, I thank you for the wonderful presentation, the expertise that you shared. And on behalf of all of us here today, I extend my gratitude. So with that, thank you so very much.
Thank you so much for the invite and for having me. And I hope the rest of the day goes well for everyone.
Thank you.
Bye-bye.
So in our schedule of events, given the generosity of Dr. Jackson and his time, we're a little bit pressed because we do indeed want to have enough time to go through our personal stigma reduction plans today. So with this, I am presenting with Kyler Groner on issues of disparities in our East Tennessee region and the impact of disparities on SUD. And so with that, Kyler, I'm going to ask that we go a little bit quickly through our presentation with the idea that people will have these slides and that perhaps we can elaborate on these at a later time and extend out some of the implications for social characteristics and substance use disorder. So Kyler, I'll turn it to you.
All right. Well, it's great to be on this call. For anybody who doesn't know me, my name is Kyler Groner, and I am an undergraduate at UT. I'm finishing up my junior year. I'm double majoring in economics and philosophy of science, and I've been working on the RCORP project, specifically Project Hope, for about 2 years now. And this is just a presentation that I put together with Dr. Meshke, as well as Peyton Prothero, who is a graduate student in the public health department at UT. And hopefully we can just kind of go through some disparities and outcomes of OUD and talk a little bit about why those disparities might exist. and possible kind of avenues to combat them. So here's the first slide. So this is the Stigma Reduction Plan worksheet. I can drop this link in the chat for people. Let's see. And if you click on that, then you can download the Stigma Plan worksheet, or you can also scan that QR code right there. So before we begin, we just wanted to give some gratitude. RCORP is funded by the Health and Services Resources Administration, as well as the Department of Health and Human Services. And we have 2 separate grants that funds that. So we just wanted to express our gratitude for that before we began. All right, so this gets into the objectives that we're going to be going over today. The first objective is going to be able to identify social differences in the prevention and treatment related to opioid use disorder. We also want to be able to appreciate the social differences of rural East Tennessee that can enhance the risk of OUD-related stigma. And finally, we want to increase access to evidence-based resources. One thing that I do want to note is that while this presentation does go over disparities of opioid use disorder, it is by no means a comprehensive study. Simply what we're trying to do is kind of get the ball rolling with creating a discussion and really kind of put this topic at the forefront of what we're thinking about. So that way, whenever we move forward and we're doing whatever work we might be engaged in aimed at preventing opioid use disorder, that in the back of our minds, we always have the idea of health justice, of reducing health inequities, and ultimately just striving for a world where everyone is more on an equal playing field in terms of being able to achieve a healthy life. So this slide has a really nice kind of definition of implicit bias. It says implicit bias are the attitudes or stereotypes that affect our understanding, actions, and decisions in an unconscious manner. And I know that the previous presentation went over these quite a bit, so I won't spend too much time on them. But as this next slide shows, implicit biases, they're pervasive, they're inescapable, and really importantly is we don't even often know that we have them. If we knew that we had them, then they wouldn't be implicit biases. Of course, they would be explicit biases. And they're in large part socialized to us. We learn them at an early age. And they can be related to explicit biases, but they are distinct mental constructs. And so they're not necessarily mutually exclusive. And they might even reinforce one another. And kind of related to that is that the implicit biases that we hold, they might not even necessarily align with our declared beliefs or reflect the stances that we're going to explicitly endorse. So for example, we might have kind of an explicit stance that all people should be treated equally, maybe regardless of race or regardless of gender. But implicitly, due to ways that we're socialized or just things that we've learned, we might have implicit biases against certain groups or certain members of certain groups. We also tend to hold these implicit biases in ways that are going to favor our own in-group, whether that is people who look like us, people who talk like us, people who are close to us in our community or come from a similar background. And finally, this is kind of the most important thing, is that implicit biases, they're malleable. They're not set in stone. And while they are inescapable, this doesn't entail the conclusion that we should just kind of be, throw our hands up and just kind of be fatalistic about it and not do anything about them. Because we do have evidence that you can gradually unlearn implicit biases. And the way that you start by doing that is really kind of introspective reflection and learning about them and paying attention to them. And the more that you're aware of your implicit biases, the more that you're able to combat them. So next we wanted to go over the socio-ecological model in public health. And so many of you might be already familiar with this model, but basically the important takeaway for this is that this model is a way of conceptualizing the fact that health is influenced by a number of different layers in our environment. So at the bottom down here, we see, an individual person, factors that might influence their health, could be their personal attitudes, their personal decisions that they make, things like that. The next layer, you have their relationships with their family and their friends and their social networks. On top of that, you have their organizations that might be in their community. On the community level, there might be relationships between these organizations. And then finally, here at the top, we've got public policies, so laws, regulations, things like that. And we do know that when it comes to having a substance use disorder, there are numerous social determinants that we can identify at different kind of levels of this model that places someone at a significantly increased risk of going on to develop a substance use disorder. So the first one is physical and mental health. As the previous presentation already discussed, trauma and resiliency, adverse childhood experiences are a significant risk factor for going on to develop a substance use disorder. Things like perception of risk, things like income and housing security, whether or not you've had a criminal justice involvement or been incarcerated, of course, availability and accessibility of care. And so we're not going to go over all of these, but we do kind of want people to have this in the back of their minds of thinking about, okay, there are certain factors in someone's life that places them at a significantly increased risk for going on and having some type of challenge when it comes to substance use. And in the later slides, we're going to see how if you're a member of a certain marginalized identity group, how you often will have an increased likelihood of experiencing one of these social determinants.
Kyler, 3 minutes.
Okay, I'll go quickly. So this is just a map of our RCORP counties. We have a 10-county region and then 3 kind of service counties. Of course, the direct service counties are Scott, Claiborne, and Koch, and then partial service are Campbell and Jefferson. So here we get into age and OUD. So if you're an adult that's 55 years or older, you have a higher rate of prescription opioid exposure than any other group. And unsurprisingly, people with disabilities are more likely than non-disabled people to be prescribed opioids or experiencing OUD, and they're also less likely to receive treatment for OUD. And kind of going along with this, veterans are also at an increased likelihood for OUD, and that relates a lot to things like PTSD or physical or mental disabilities or challenges that might result from being a veteran. And then down here, you can see in the RCORP region, we have really a much older population than Tennessee and the rest of the country. We have more veterans than Tennessee and the rest of the country, and we have a significantly higher proportion of our population that is disabled. So next, we can get into race and OUD. So communities of color have higher rates of unemployment, housing security, and incarceration than white people. This is largely due to things like labor market discrimination or housing discrimination. And while Black and white Americans use and sell drugs at similar rates, Black people are significantly more likely to be arrested or incarcerated for this. In fact, they're about 6.5 times more likely to be incarcerated for a drug-related offense. And if you're Black, you're less likely to receive treatment for a substance use disorder, counseling, or overdose prevention. And Black individuals that do receive treatment for OUD are much more likely to receive methadone, which is much more surveillance and often stigmatized than buprenorphine, which you can take home and you don't have to go to a clinic every day. And so here we have kind of some of the numbers of kind of the racial breakdown of the RCORP region and then Tennessee in the US. And while much of this region is predominantly white, we do want to highlight that this is a significant region, and people of color do exist here and they always have existed here. And certain counties have much higher rates of diversity than others. For example, Morristown, which is in Hamilton County, one of the RCORP counties, has about a 20% Hispanic population. And so that's significant when looking into this, because it varies from community to community. Next, we can see sex and OUD. So women are much more vulnerable to OUD than men. They're more likely to be prescribed opioids. They're more likely to experience depression and receive pain-related diagnoses. And they're more likely to be given higher doses of opioids and for longer durations than men. And women, especially if they're pregnant, are vastly underrepresented in treatment centers. Next, we can kind of get into some of the intersections of sexual orientation and rural status and OUD. So LGBT youth are at a significantly heightened risk for things like bullying and harassment, which often results in mental health struggles. And they're at a significantly increased risk for suicide related behaviors. And so as we can see, thinking back to that first slide, mental health is a huge determinant of developing a substance use disorder. So given this, it's kind of unsurprising that if you are LGBT, you are placed at a higher risk of going on to develop a substance use disorder. And then here we can kind of get into some of the stuff about rural counties. Rural counties face unique challenges because they have less providers who are certified to treat OUD. And of course, as the prior presentation mentioned, rural counties do kind of have unique challenges in terms of stigma, where it's smaller and everybody knows everybody. Here's just a slide about insurance, employment, and OUD. Adults on Medicaid or with no insurance coverage have a greater risk of OUD than those with private insurance. People on Medicaid are less likely to have access to evidence-based treatment. And it's estimated that over 60% of people actually refuse treatment for Medicaid enrollees. And low socioeconomic status and unemployment are related to a greater risk of fatal opioid overdose. And here we can see at the bottom, the RCORP region does have a much higher proportion of its residents who are on Medicaid or who do live in poverty than the rest of the Tennessee or the rest of the country. And with that, I will let Dr. Meshke take over.
Excellent. Thank you so much, Kyler, for giving us an overview of things that are happening in our region. I'm going to very quickly go over the following slides so that we can get to our activity. And just want to point out that although Kyler did a fantastic job of discussing how different social characteristics can impact our risk of OUD, the fact of the matter is that we all have different layers. For example, my lens is as a white woman who grew up in rural Minnesota in a Midwestern area with a father who had alcohol use disorder. This is part of my lens and part of my influences when it comes to my implicit bias. So with this, when we're talking about intersectionality, I have different layers that will affect how people treat me. And I also have different layers that affect my lens on how I view others. Next. This just provides a slide to show how different characteristics can intersect. Next. This one, and you can look at this at greater detail once you are back in your office and ready to think hard. But this is just shows the complexity of how intersectionality can play out, that the stigma may not only be associated with somebody's OUD condition, but it may also be affiliated with the other social characteristics that they identify with. Next. And just to give an example of this, I wanted to touch a little bit on a study that we conducted here in Knoxville. And although it was conducted at 2 MOUD treatment facilities here in the county, it does represent patients from all 16 counties. And just to show you the intersectionality that can occur with women of childbearing years, which is one of the more highly stigmatized group in relation, particularly if they are pregnant. So we can look at their identification with communities of color. We can see that their rates of unemployment and home and being without a home is also quite high, that their insurance levels are quite low, and that as far as challenges in paying just basic housing and utility costs is extremely high, with over half of the group represented in that region. Next, please. This is just, again, providing you some of the intersections that we can look at as far as guesstimating the number of people in our region, because we have over 90,000 people who are living in the RCORP region. And with that, when we're looking at is 15% at the lowest of being women of reproductive age, we are looking at almost 10,000 women. So with that, thinking through how this intersectionality occurs. And in the previous slides, when we were looking at women enrolled in MOUD, these are the women who actually have access to treatment. So these may actually be women who have fewer challenges than those who do not have access to treatment. Next, please. We have a variety of resources to add to those that Dr. Jackson shared. And if you're wondering about your implicit bias or you're curious, and I've done this exam several times, the first one, Project Implicit, allows you to take quizzes to actually assess where you lie on implicit bias. It helps you to become more aware. Even as a woman, I may hold implicit bias against women in relation to some fields of study or their contributions, for example, in employment. So this is a very interesting quiz that you may want to check into if you haven't already. Next, please. We also, Kyler was so good about putting together a list of organizations and resources that are relevant to East Tennessee. So if you are intrigued by the idea of implicit bias, intersectionality, what you can do to further reduce stigma associated with any of the social characteristics that we described today, I very much encourage you to seek out local resources. Next, please. With this, we are turning to the stigma reduction plan, and we are pretty close on time here. So with this, we have created breakout groups, thanks to June and Jennifer. And with that, you have now your plan. And if you are like me, you've started filling it out with your information as the presentation was going on. With this, you are going to be given 15 minutes to think, well, actually, it's probably more like 12 now, 12 minutes to work in your breakout rooms to share some of your ideas that you are comfortable sharing, some of your strategies, and hopefully learn more about strategies that others are taking that you might want to incorporate into your plan. And then we'll come back and just in the chat box, share some of our thoughts and ideas and reactions to the items that were shared and the strategies that are going to be taken. And then we will gather all of that information and we will again share that with you after the training session has ended. So with that, I'm going to ask Jennifer to please start our breakout groups. And again, have your My Stigma Reduction Plan ready, and you will be talking through what you're thinking about in relation to the 4 questions with those in your breakout groups. Okay. So welcome back, everyone. I hope you had an informative conversation with your small group breakouts. And at this point, I would like to ask if you had any takeaways. And we're a bit smaller group now, so if you're comfortable unmuting and sharing any thoughts that you have. Otherwise, please feel free to put it in the chat, because we will be taking the chat and we will be summarizing this, including all of the URL links that have been shared. So you will not miss anything in the chat as far as summaries. So with that, did anybody leave with some new takeaways or intentions?
Yes, this is Jane Crow, and I'm speaking on James Arnett's microphone. And hey, so I'm the harm reduction program manager at Knox County Health Department, and James Arnett is a team member. And you can't see us on camera, but my whole team is watching together, and we've really enjoyed it. Hello, y'all. And in our group was Jan and Courtney and someone with a phone number that I didn't recognize. But one of the things that we talked about was we love the unconditional positive regard piece a lot, and then using that as something to always come back to. And none of us had heard that before. We had heard of unconditional love, but not unconditional positive regard. So that was really beautiful. And we also really like the different types of stigma and breaking those down. I had never seen that. And I think we're going to get a copy of the slides, because I want to study this more about the perceived, anticipated, internalized, and experienced stigma. That was very interesting. And a third point that we found interesting was the vast difference between what providers see as a barrier to treatment versus what patients see, and how patients immediately saw the stigma as a barrier and providers didn't see that there was a problem. And so we found that very telling, something to really keep in mind there.
Excellent. Lots of great takeaways. Thank you for sharing that, Jane. And I love the fact that you have colleagues with you there where you can help remind one another of what your intentions were and maybe check in to see how people are feeling about their progress. That's great.